Good afternoon and welcome to our second town hall meeting. I am Catherine, Manager of Quality Programs. Before we get started, let us go over a few rules of engagement. We request that your cameras are off and that you stay muted during the entirety of today's call. All questions must be posted in the general chat with the standard reference. Please see the example that I posted earlier. We will do our best to get through all questions. In the event we run out of time, we will provide written responses to any unanswered questions after we have time to compile all the responses. The purpose of today's call is to review the 2022 standards and answer any questions you may have in regards to these changes and updates. Any other questions regarding accreditation applications, survey process, or status, etc., you may email us at quality@ucaoa.org. Today's meeting is being recorded and will be made available in our accreditation resources link at a future date. And now, without further ado, our Executive Director, the Tsarina of Quality, Tracy No E Patterson.
Oh, that's quite the introduction, Ms. Catherine. So thank you, everybody, for jumping on today's call. I'm very glad to see you all here and have a chance to cover the 22 standards with you. We were quite excited about the changes we've been able to make to those, and we hope you all are as well. For today's agenda, I'm going to cover some things about the standard release and upcoming updates. We're going to talk about the new formats both in Word and Excel. We're then going to take all of the questions that were submitted in advance, and then after that, any additional questions that were posted during this call in the chat. So as those of you that have been with us for a while, you would have noticed that we didn't release standards effective until July 1st of this year. We have made a decision to move from an annual January 1st release of standards to an even year release of standards effective July 1st. So instead of getting revised standards every year, it's going to a 2-year cycle. Now, with that change and that gap of time, we of course will make any necessary updates on a case-by-case basis. And typically what we expect that to be is if there's a change in a regulation, so forth, that would be impactful and tied to our standards, we of course would make that change and push that out. That would be the same that we would have done 2 years ago on an annual schedule. But otherwise we are moving to a 2-year cycle. And then we will post onto the Resource Center available through links anytime we update them because of a minor issue such as a typo, something wrong in the key or legend, something minor that's discovered. As people send us feedback, we sometimes discover those errors. And then if there is anything of substance, we will issue out no versions, of course, via the email and the key contacts. With that said, I'm going to go through and start going through the actual manuals. We're going to start with the Word version before jumping into the Excel. With the Word version, I'm going to go ahead and share my screen to do this. So with the manuals, we made a concise, conscious decision to get very concise in the language and pull out extra information. So there used to be some checklist features and some other things. That items many times are issued when we schedule the survey or will be issued under separate cover. But we wanted to clarify language, simplify language, simplify the format, make it a bigger font, those type of things. So with those thoughts in mind, that is probably the majority of the changes. We actually ended up with very few additions. We have some of our additions are purely for clarification. You'll see a lot of change symbols, that type of thing when we get to the key section. And so not a lot of new content, but I will highlight a couple of the new content in just a little bit. And we still have the main 7 key areas added in with certification criteria. If you are used to the old manual, you notice that we moved from separating out comprehensive and occupational, and we've combined those sections and just indicated that they're together. The other major thing is we had received some feedback that sometimes the alpha key in regards to additions, changes, eliminations, etc. policy was sometimes confusing. They may say, is D delete, D documentation, etc. And so we've moved to a symbol format in the key in the Word version. Now in Excel that didn't quite work out well, so it's still alpha, but here the other major change was here. The other thing that we've done is we no longer link the glossary terms that became problematic in the Word format, and so we've now moved to an underline feature. Other changes that we've made, I'm going to use the certification section to talk about that, is we moved away from the use of standards and expectations, and now everything is listed as a standard. The column that was reserved for success demonstrators in many cases was confusing to individuals because they thought they were requirements when they were not. So anything that's a note, success demonstrated, a recommended practice is now listed at the bottom of the standard in that section and noted as such. So slightly smaller font, but we've moved that away, and now you just have a single column for your notes in regards to your compliance and progress in those. So a lot of format cleanup here, and what we were able to do, of course, was to increase the font with that. Before I move on to the format of the Excel, I'm going to actually talk about some of the standard changes that we had using the Word document. So not a lot of, so right here, just with the new key, you have the documentation notice requirements posted here. With these format changes, we had a huge amount of changes. And so this change symbol was used only when we thought it was a substantial change or it was a standard that people struggled to understand historically. And so with that clarity of language, we thought it may represent a significant change to individuals. If we had marked every time that we had made a change in a word or a sentence structure, etc., pretty much every standard would have had that symbol. So we were selective in which ones we marked with the change symbol. Of course, with all releases of new standards, we recommend that you read every standard with a new release, just to make sure you're still in compliance with it, regardless of how it's marked in the key. So as I said, not a lot of changes in the certification criteria, with the exception of we did move the occupational health scope criteria under certification criteria, and they're indicated that only if you're applying for this particular scope as a standalone or in addition to your comprehensive, you would need to comply with the standard CC 11 through 14. Not a lot of changes in the governance section. And so then I'm going to slide down to health record maintenance. We had probably a couple handfuls of things marked as additions in this standard. For example, this one right here was marked as an addition, but this is one that being in an actual EHR and not on paper records was something that was there, but just not as a note in the last standard release. And so it was permanently made a standard and marked as an add, but you know, not a substantial change or new addition to it. It's just the format change caused it to be an add into the system. So I wanted to focus on the ones that really I think there's going to be result in you taking activity or work for those of you that are in the renewal phase versus the initials that you haven't seen before. There is a mention of one here, HRM4C, that is actually tied to a PCP standard, and I'm going to talk about it there, but really nothing of major note that I wanted to point out in the HRM section, nor was there anything that I'm going to point out in regards to the human resources section. So if you have questions on either of those sections of standards or three, governance, HRM, or HR, please take this opportunity to post the question into the chat and we'll address them after I get through the major changes. And sorry if the scrolling makes anybody dizzy. Sometimes makes me dizzy. The first one I want to talk about in patient care processes is patient care process number 5. And those came into play with O and P were the ads. O was really about pulling this out and expanding on the requirement, and it was listed as an ad. But P is, there are 2 standards, PCP5 and PCP7, where we have added scope into the standards. And the first one here with P is that we are requiring a small amount of medications be present. For the most part, 99% of organizations plus out there have medications that were that work for their population to serve. The old standard said, put your formulary together, design it for the population that you serve, and some people's response was, we don't need to have medications, we've thought about it. And we do feel that with an urgent care center that there should be at minimum a handful of medications that are available for both your adult and pediatric patients. So those have been specified in PCP 5P. And if you have any particular questions on a particular medication or an alternative to a medication, please reach out to us actually through the quality, and we can dig into the actual medications there. But if you do have questions about how this will be surveyed to or something like that, please post that into chat. The other one I wanted to talk about was down in PCP7. And with PCP7, we actually took this opportunity to really rewrite and clean up the language in the whole PC7 laboratory standard section. So you'll notice that all of these have some change symbols or add symbols, and that is because we did a lot of work for this particular standard to add clarity. So please spend some time in it. It's the same as with the medications. The standard required a CLIA waiver to do some on-site testing. And we have specified that at minimum these 3 tests, are added into your operations. Rapid urinalysis, urine pregnancy, and then finger stick blood glucose. Now, as with all things, the majority of urgent care centers are doing way more than these point of care testing, but these are the 3 that have been added into the standard. As I mentioned earlier, we have added PCP 9C, and this is in regards to restraint. This addition is tied to the HMR 4, where if you do use restraints, it needs to be documented into your visit. The reason this one came about is because we were noticing upon survey that many organizations and centers had restraints in it, but not necessarily under the direction of leadership. Came in place on an initial order when the clinic opened. It came in when the radiology company, put in the equipment and some of the supplies that came with it. It maybe came in when they bought their emergency medication kits and et cetera. They would get some restraints and stuff similar to that, but not really any education, process, policy when they got to be used, et cetera. So the requirement for the standard is if it is allowed, that certain things are defined by policy. And then restraints such as holding is the first 3 bullet points, and then afterwards down here is if you use actual restraint devices. So when we did the release of the advanced copy, this is one that we went back in and clarified even further, refined before it was released in the final version. So please do take some time to look at PCP 9C. Scrolling down, only a minor thing to mention in patient rights and responsibilities. And that is that there used to be rights defined under PRR 5-1, responsibilities defined as PRR 5-2, and it was kind of to say it, weirdly done. And so we eliminated 5 in its entirety and cleaned up the language and posted it into PRR 6. So not necessarily a change in what was required, but really a substantial change in the cleanup of the language here. So you'll see that there. And the only thing that was added per se is education of the rights is documented. So a lot of times on survey, staff, the workforce was unable to articulate those rights and be able to point them out or find them. So from an ad perspective, education of your organization's patient rights and responsibilities is done with your workforce was the ad here. And so those were the major changes in the actual standards that I wanted to talk about. Like the PRR 5 and 6, I also want to point out in the quality improvement section that in QI1, sorry, just scrolling to it, we did a lot of cleanup in QI1. It used to be A through I or A through L. Now it was a long section. We did a lot of work to help clean that up and clarify that. So you now just have QI1 with A and B. And then the other thing is we used to have QI 8 and 9. That was duplicative, kind of talking about the same subject matter, a little different. Those were combined and converted into QI 11. So requirements are pretty much the same. It's just the way we're asking for it in the standard that it is now under. Next, I'm going to go ahead and jump into Excel and talk a little bit about the Excel version. So with the standards, we've always released it in that Word format. And this year we went to the PDF, the Word, and the Excel. For many years, organizations have been asking for an Excel format. Many will use it to help track percentage of completion, make assignments, etc. So we're happy to announce that we've now released it in Excel. There were some key changes to the Excel version, however, to make that happen. Anything that was an eliminated standard that's currently listed in the Word as intentionally blank is just not in the Excel version. So we've only placed into Excel those standards that actually have a requirement. The other thing is, as I mentioned before, the use of the key symbols makes Excel is a little more difficult in Excel. So we've converted those back to the alpha representations in the key. We also did not underline the key glossary definitions within that. Some other formatting things based on how returns work, etc. In this version, each key area has its own separate tab. So we've put the key in place. We've referenced the number in its own column, the standard number. The standard is still there in the description. The other thing that was made here is you're not going to see recommended practice success demonstrator notes. You're just going to see standard language. You then have a status column in a notes. Now, the nice thing about Excel is you can do things such as if you want to add a key contact, because that's, you may have made assignments on that. You can just do that and make your own changes here and then start, listing out people that are assigned to that particular standard. So the nice thing about Excel is you can expand it, put in the things that you want to put into it, and go from there. We used some data validation to help track progress. And what that means in the status column is that you use this little drop-down menu on the side, and you can pick any of these statuses as a place. So I can say, okay, we've started our work. These certifications are now in progress. Oh, this one's already completed. And so you can go through and make the changes there. How this ties into the Excel version is if you go over to progress tracking, you can see that I just changed 2 of the certifications. There's 32 in total. 2 of them into in progress, 1 into completed, and now only 29 of them are listed as not yet started. So you are basically 3% completed within this section of the key area, or 0.3% across the board. So it's a nice way for you to track. Now, if you guys don't like this feature of this, I would just recommend that you delete this tab, and then you can write whatever you want in status, or you can even delete the status columns in the individual tabs for each key area. Now, some of you might be thinking, I don't like the terms that they chose here. Those drop downs come right from here. So if you wanted to say, instead of saying in progress, you wanted to mark this as less than 50% complete, and this one more than 50%. You can change these to whatever that you want. You'll see that they went to 0, however. So when I go back over here, because they're still not yet started, you have to go back and adjust this. But you can see that they've automatically adjusted. So you now can do less than 50%. This one's completed. This one can be more than 50%, etc. And if we go back over here, you can see now how they've started to fill in based on their selections. So you can always go in and change these. The other thing that you can do is if you insert here and you say sample add, and then copy these down here and jump over onto CCC, you can change this and the sample add has been added. And then when you come back over here, you can see now one is here. The other thing that you're going to want to do is, because they're added in here, to get your totals done, you are going to want to insert. These are based on, you can just use a formula to copy those down, and it looks like I inserted one row too many, so let me just delete that. And then just copy the top row formula down, and it's going to fix that all the way through. So for those of you that have a basic understanding of Excel, you can really use this progress tracking to help. If you don't, as I said before, you can always just delete it out, but there are some options now to help you at least baseline to do some tracking. For those of you that are Google Sheets, etc., I'm sure you have expertise in those, and you'll be able to take this file and convert it over. I'm an Excel person myself, so that's where we ended up putting this in. So just kind of for you to see how that progress tracking is, and if it's beneficial to you all, you can start to use it. Now I'm just going to undelete some of these changes so I don't accidentally save them. But that is how the progress tracker. You'll notice that one of the statuses was header. And those are related to standard letters that still don't have an expectation. So PCB2 is medical care services, but the actual requirements aren't until you get to A, B, C, D. So because this exists in the standard, we didn't want it to be marked as complete or not complete and mess up the statistics. So we list it as a header, and then it becomes subtracted out of the total for the total percentage. So that's the kind of the new format related to Excel. Before I jump into the questions aspect about the standards, the different standards that were submitted in, Catherine, did we have any format questions?
No, we did not have any format questions.
Okay. So then, guys, we're going to go ahead and jump into, first off, the questions that were submitted into advance. And I'm going to scroll to the actual standard with those questions when they come up, when we know when it's actually tied to a particular standard to help. But Catherine, you want to go ahead and have a start with the first one?
Yes, absolutely. So these were, as Tracy said, submitted in advance, and then we will get to the ones that have been posted in the chat since we've started. So if you haven't already posted your question, you can go ahead and start posting them now, and we will get to those after these. Our first question was in regards to standard reference CC3D. Are the standards still the same for having registered, licensed, or licensed rad techs on staff?
So yes, so in regards to CC3, CC3D, the requirement is for your comprehensive scope that you have, and for most of the scopes, is that you have X-ray on site, which includes both the equipment and the staff to obtain and read those images. Now, with that, every state is different. So if your state says only RTs, or they have RTs in limited scope, if they have, you know, a program where you can train your MAs, or if they have a thing that says it's allowed by physicians or it's allowed by APCs with an additional certificate, etc. We will survey to whatever your state requires for you for taking those images. So, you know, do you have to have RTs? Only if your state requires that you have RTs to take those x-rays. But x-rays, yes, are still a requirement, and how that is staffed is dependent on the state that you operate in. Next question, Catherine.
Next question, CC 11C, please clarify if providing services via a third-party vendor only applies to 11C and not to 11A and 11B.
So yes, so with the services outlined in CC 11, some of them, like A, is the DOT physical, some urine drug screen collections, visual acuity, et cetera, and B. So these are ones that you need to provide on site yourself. And then these here, breath alcohol testing, full UDS testing, which you could send to the lab, that's the third party, some respiratory fit testing. Those you can provide directly yourself or arrange through a third-party vendor, but they are items that under our accreditation of occupational health, you'll have to provide that service. Just for these in particular, you can use a third-party vendor to accomplish those. But these up here in B, you have to provide directly yourself. The other thing to note on occupational health, when you are listing occupational health scope as a secondary scope to your urgent care comprehensive scope, anytime there is a secondary scope, that is by center, not by organization. So for those of you that have occupational health services only at certain centers and not at every center, you can still apply for occupational health to be added to particular centers when we perform your accreditation. Next question, Catherine.
Okay. GOV2H, can you provide an example of disclosure of conflict?
Okay. Conflict of interest policy is where your staff and your providers notify you that they potentially have a conflict of interest because of a relationship or ownership in a product company provider that they may refer a patient to for services. And so a procedure for this is at new hire annually, typically, that you require that your workforce fill out a form, and that form states and lists their conflicts of interest and also affirms if they have no conflict of interest. It's not, if you have a conflict, turn it in. It's like, tell us if you have a conflict, and if you don't, you have to tell us that you don't have one as well. Most often, conflict of interest disclosures are handled under your compliance plan and your compliance staff, or others do also choose to handle those through their HR departments as well. Next question.
Yes. So this was a general under HRM. Process if EMR is changed during a cycle and documents are read-only files.
Okay. With the requirement, which is HRM 1D, that they have to be in electronic format, doesn't mean that you have to stay with the same EHR. We understand the need to switch electronic medical records, and many times when you do so, the historical visits are, some demographics come over, but in many cases, those visit notes come over as PDFs, and then they're transferred into the new EHR. That's perfectly acceptable. The requirement there is it is electronic. It's an attachment. It's a document just like a lab report, and you and a surveyor and a patient needing a copy, et cetera, would still have access to it.
Okay, next question is PCP5P. They had removed nitro from their formulary, so do they need to add it back?
Yeah, so let me scroll. we jumped HR. We spend a lot of time usually on HR. I wasn't expecting that. PCP5. So with the medications that are listed here, reach out if you have a particular concern on one medication. In general, yes, if they're on this list, they need to be present. If there's some alternative mechanism to address this item, we would love to hear from you and walk through that. Would like to hear from you if you've removed it from your formula and the reason for that. But so I would tell you to do that. But in general, the answer is yes, if the medications are listed here, they need to be present or an equivalent to them needs to be present, and just reach out individually on those particular items if you have a concern on one of them.
And we had another question under that one, so from this group, so I'm just going to go ahead and ask it since we're already here. The question is, if you are strictly a pediatrics facility, nitroglycerin and chewable aspirin is still required?
So with the pediatric only, we did not make a particular variance on that, but we do allow that type of scope to happen. So once again, just reach out to us on that, and it sounds reasonable, so there would probably be an exception listed, but with all of those type of things, when we make exceptions to standards, they do get reviewed by committee. But for that case, I understand the logic, so please just, as that org, submit that into us.
The next question, PCP 5-1, can the urgent care have its own pharmacy?
Yes, so if your state allows you to do a pharmacy, or I think in like the state of Texas, it's like a pharmacy D license or something, a particular type of pharmacy. As an example, this is another thing where this pharmacy and who can have them is controlled at your state level. So yes, if you meet the state requirements and you go through and do the licensure that you need to do so, yes, you can have a pharmacy. Many of our locations that actually do more than administration will do dispensing, and a lot of times the medical board does that with an additional certificate of license tied to the provider's medical license, or they have a CDS program that takes that into account. And so PCP 5-1 is dispensing, but the same type of questions we would apply to the pharmacy department that we would apply to the dispensing department about following their regulations, and having that patient be available to have somebody to talk to, the physician to talk through about their questions in regards to the medications that they're taking home with them.
Next question was PCP 9C, who decides if patient restraint is allowed? I don't believe we use them. Do we have to?
Go far enough. No, you do not have to allow for patient restraints or use them. If it is allowed, you have to have a policy that meets this, and you need to define this for your staff. So, but no, we are not requiring that you have patient restraints.
And
you'll decide that with your medical leadership.
And our last one that was pre-submitted is under QI3. It's more of a general question regarding reaccreditation and the public health emergency. Over the last 2 years, how are surveyors to look at historical data for, say, patient callbacks that could have gaps be addressed? Is there any latitude allowed when surveyors are in-house?
So if I'm understanding this question correctly, it was in regards to you may have had a program in place pre-COVID that had 100% of patient callbacks, et cetera, or you used to have 100% results callbacks and you moved forward and it was more only call with positives or that type of thing. What should have happened ideally was that your process should have been updated and therefore rolled into your QI initiatives. It sounds by this question that maybe it wasn't, or there was a temporary stop and so the records don't exist. Anytime for any measure in the QI section, when a measure is missed, we work with our organizations about what they're going to do to fix it and how they're going to prevent it in the future. And that's that's how we approach all of these standards. You know, with a survey, with any accreditation, it's not that you have to be 100% on survey to have your accreditation, right? There's typically, you know, things that pop up, a small handful of things that pop up, but things that pop up, and we work with organizations about, and this is QI talks about it, right? It's the Plan, Do, Study, Act. It's about, yes, we missed something. Yes, something happened. Let's study it, find out why. Let's address our process, our procedure, our education, whatever it is, implement something new, and then go back and audit to see if it's effective. And so that is the same thing we would handle in these cases when surveyors come on site. It's to look at things that didn't happen, and that's how we do our action required going forward. So, and really for many organizations, when you know there's a miss, the best thing you can do pre-survey is just do that, you know, study it, find a plan to prevent it going forward, do the steps that you need to do, and have it implemented by the time we get there.
Okay, starting with our questions from today. Do all patient encounters have to be electronic? Does it mean no paper charts at all? HRM 1D.
Okay. So as I scroll up with that, yes. Now there are going to be times when you are on paper charts. You can have your internet connection is down. There's a maintenance issue with your EHR. You are doing a health fair, or you've gone on site to render some services with an employer group or something of that nature, and you have paper records. What that does is, as part of your HRM, you need to have a process in place as part of your policies that say when those records happen, we document on paper, we have a list of what gets added in, you know, so a lot of times update the medications, impactful for the next visit, update the allergies and actually put them into the EHR, and then the main body of the visit note is then scanned in as a PDF and held as a document within there for when you are down. But in general, just to answer that, yes, they need to be in the EHR. It's just there are exceptions to that based on certain events that would put you on paper for the actual visit, and then you have your process and your policy of how that information gets uploaded and shared into your EHR.
There are two under PCP. I believe the standard reference might be mislabeled, but this is for 4P, but then there's another one for 5P, and it kind of goes along the same.
It's a medication
Yeah,
question.
the medication question. It's do all medications need to be available in pediatric doses too? For example, chewable aspirin, nitroglycerin, naloxone. And then another question was, do we need to carry both pediatric and adult doses?
Yeah, so if you are a center that's treating all ages, you need to carry pediatric and adult doses. In regards to a particular medication on the list, if it's recommended for that age range for a treatment of, especially an emergency situation, then yes, you would need to carry it. If it's not recommended for pediatrics, then no, you would not need to carry it. You would only have the adult dosage.
Okay.
Were there any more?
Yes, I was talking while I was muted.
Okay.
So this last one did not have a standards reference. However, it was in regards to the X-ray techs again, just to clarify that they don't have to have a national certification.
No, unless your organization or state licensing department requires it.
Okay.
We do not have a requirement.
So that was all of the questions that were pre-submitted. And there is another one that just popped in. It says, I have always assumed the burden of proof for destruction of biohazard material would be on the regulatory body that oversees those facilities. What was the reason for requiring proof of destruction?
So your biohazard is your biohazard until it is actually destroyed. And so the manifest requirement is in regards to just that. They should be able to demonstrate that it was destroyed and that you don't continue to send biohazardous to a company that's not following regulation. So they're required to do that manifest. They're required to give you a copy of that, and that is your quality check to ensure that the waste you generate at your site was actually destroyed.
Okay, does anybody else have any questions? Please post them in the chat. If you have called in and you do not have access to the chat, you can email us at quality@ucaoa.org. You can email your questions over to us. If we don't get a chance to get to them today, we will definitely get back to you on those.
Okay, so Catherine and I are going to hang out for the next 4 minutes until 10:02. For those of you that have your questions answered, I want to just thank you all for being here and taking the last 45 minutes to go through this with us and allowing us to share this. Hopefully it added some knowledge and clarity. If you have anything that pops up afterwards, please definitely reach out to us at quality@ucaoa.org. And yeah, once again, just thank you. So we'll be here for a few more minutes in case people are still working on their questions, but thank you all.